it seems, as I've been living in these numbers for months, as I'm sure you have.
Yeah.
It seems like our mortality rate early on, 7%, 6%, whatever it was. I've been studying a lot of the numbers as to where we might actually be. And I know that you never know these things, and you may never truly know because we don't know definitively how many cases we've had. And obviously
Right.
that's a big part of the equation.
Yeah, in
for the
science we call
mortality
that
rate.
not knowing the denominator. We don't know how many people actually got infected, so we don't know
Yeah,
the true
I mean,
denominator.
the
Yeah.
deaths is a fixed number, we think.
Right.
I mean, it's probably off one way or another, who knows.
Yeah.
But that's kind of what I want to dive into. And I think where I really want to go, if your numbers and your profession also believe this, is how deadly this is today compared to what it was, say, March or April. Does that make sense?
Yeah, no, that makes sense. That makes sense.
Okay.
I don't know if we're going to be able to give you hard numbers. But
Yeah,
we
I
can
know.
give you ballpark.
I've bounced all over trying to figure out, I know the CDC and the World Health tend to agree, and I found a lot of studies that back this up, that for every case we've diagnosed, there's likely 10 we haven't.
Yeah, that's about
And
right.
they've done that through serology tests,
Right.
I guess, to see that, you have the antibody, so at some point you must have had the virus, developed the antibody, therefore
Exactly.
you actually had coronavirus.
Right.
So if
I've done a couple of those tests in my day too. So it's called seroepidemiology, where you're able to look and see who has been exposed. Yes.
So can you explain that a little bit? So I know obviously people think, well, you have coronavirus if you've taken the test and you've tested positive.
Right.
If you test positive for the antibodies, is that also, does that definitively mean that at some point you carried the coronavirus, you didn't even know it, and now you have the antibody?
Right. It depends on which test. There are many, many different types of coronavirus antibody tests out there. And the coronavirus antibodies just tell you whether or not you have an antibody against this coronavirus. And most of the coronavirus antibody tests now are pretty sensitive and pretty specific. And specific is really important because there's a whole bunch of other coronaviruses out there. And if there's a bunch of coronaviruses, you have a coronavirus antibody, how do you know that it's the actual bad coronavirus, the SARS-2 coronavirus, versus any of these other, coronaviruses out there that have been around for decades?
Okay. On that point, most of the studies that I've found, they do mention specifically that the antibody for the SARS-2 was present. Does that then mean if they say that the antibody was found for the SARS-2, COVID-19 SARS-2, that indeed you had it? Or is it possible for someone to have that antibody without ever having the SARS-2?
Well, for the most part, generally, if you have an antibody in your blood that is against the SARS-2, it tells you that your immune system has experienced this infection that has processed itself such that it will protect you or try to protect you from further infection going forward. So if you have an antibody in your blood, it really means that your immune system has encountered and responded against that virus. Now, it may have happened without you ever even knowing you got sick or infected, and that happens actually a lot with a whole bunch of different viruses out there.
Right.
Do
we know, Doc, what the percentage is of the people that experience no symptoms based on these serology tests? It seems like if for every case we know about, there's another 10 we don't, it seems like the overwhelming majority of these infections would be asymptomatic.
Right. And we certainly do see that there are a lot of people who are asymptomatic even when they get tested. We're starting to see more and more asymptomatic people now that we have the ability to test people who aren't even having symptoms. And so you have a lot of places that are able to test like what we do before you even get any procedure or before you come into the hospital. Whether you have symptoms or not, we will test you for the coronavirus. And we're finding somewhere around 40 to 60% of people will actually have the presence of the coronavirus, but they're not having any symptoms.
Wow.
So we do
Is that,
believe that there are a lot of people that will not develop at least symptoms that they recognize as coronavirus symptoms.
wow, that's interesting. So the equation for the mortality rate is quite simple. You divide, you take the number of deaths and you divide that by the number of known cases.
Right.
And I did that for Ohio. I also did that for the United States. And amazingly, and or maybe not, I mean, when you're talking about such a large sample size, you would expect that the formula would lead to similar results for a subpopulation as large as Ohio.
Right.
And what I found was in the 9 million diagnosed cases in the United States and the now 230,000 deaths, that leaves you with a mortality rate of 2.5%. Which is alarming, obviously. Yeah. It's much lower than what we thought it to be in March, but it's still alarming. But if you use the CDC and the WHO's numbers as 10 cases undiagnosed for every diagnosed, you then would times that 9 million in the United States, and you would get 90 million infections, which is more than a quarter of our entire population. Mm-hmm. But more significantly, if you do that, and then you take the 230,000 deaths and divide that now by the number of estimated cases based on these serology tests, which is 90 million, you get a mortality rate of 0.25.
Yeah.
Which obviously is still, you don't want to see that. That's still a lot of fatalities.
Yeah.
But compared to what we thought it was in March, when we were shutting things down, we thought this was killing 5 out of every 100 people that came into contact with it. Now that we may have a better handle on that number, how do we explain that it's gone from 6% all the way down to 0.25%? What are we doing now we weren't doing in March?
Well, first thing is that there's still a lot of assumptions going on there, right? We're still assuming that it's 1 for every 10. That there's 10 undiagnosed people out there. It's still a lot, even when you are having a very small case fatality percentage, like 0.25%. When you multiply that against, let's say, everybody in the United States, a huge number, a small percentage of a huge number is still a huge number. And 230,000 people is still a lot of people, whether it's 0.25% or 2.5. It don't matter. It's just an awful situation. But still, I would say that when you look at the rates, and we've had 3 waves, we're moving into our 3rd wave right now.
Right.
The first wave, we had the highest case fatality between recognized and people who have died. We had the highest rate. Sure. In the middle, it's less, and at least in the 2nd wave, it was less than the 1st. And in the 3rd wave, we are hoping, and right now it's kind of trending that way, that'll even be less than the 2nd, which is great. It tells us that we are learning how to care for a lot of our patients. We're learning how to recognize things earlier, not just diagnose earlier, but recognizing those complications that people with coronavirus have, like their renal complications, their kidneys have a problem, or their how to treat their lungs better. So we're able to treat people better. We are also able to give treatments that we didn't have in the first round.
Sure.
Right? When the first go around, we did not have any medicines to treat. Now we have 2 that are FDA approved. There's a lot of others that are coming down the pipeline. And we're between our being able to care for them better, our being able to actually have some sort of treatment. And the 3rd thing, which is things that we're doing here as part of our research, is actually looking, has the virus changed? It very well may be that the virus itself in the beginning was a lot more aggressive. And then as these mutations occur, the virus becomes less and less aggressive as it, kind of evolves to become a little more stable virus. Many of those viruses that we had out there, remember, we, pandemic flu back in 2009, but we even had, all bad influenzas, bad coronaviruses. They all came into humanity at some point in time, and they were really bad at the beginning. But then they basically get weaker and weaker, and they get better and better, and we are able to survive with them a little bit longer just through evolution. The virus itself, and this is just me telling you how I think, the virus doesn't want to kill us. The virus does a job. It says, I want to infect you, I want to make 1 million virus babies, and I want to get out. That's it. It just wants to spread. it doesn't want to kill us. It wants us to continue to move and pass it to other people who will mildly get ill, but then we'll also make more millions of babies and continue to spread. That's how a virus is successful. That's why some of the most successful respiratory viruses, rhinovirus, basically doesn't cause a lot of severe complications in most people, but it's so mild that we always came to work, we always went to school, we always sent our kids to daycare when they have a little bit of a runny nose because it was rhinovirus and it didn't cause a lot of problems.
Yeah.
Here,
It's fascinating.
we have a much more aggressive virus that we can't tell whether it's rhino, whether it's flu, or whether it's coronavirus. And so now we're all basically clamped down to make sure that anybody who has any sickness is staying home.
It's fascinating. I've never heard that theory before, but it's fascinating to me because per your description, fatality is actually an unintended consequence of the virus, because if it kills the host, then it eliminates possibility of spread from that infection. So I've never thought of it that way, but that's a great explanation and it makes perfect sense.
And it actually is one of the reasons why. This is not the first coronavirus we've had. We've actually had 3 coronavirus global outbreaks in the last 20 years.
Wow.
The SARS coronavirus and the MERS coronavirus. SARS in 2003, MERS in 2012. These things, and specifically for MERS has been smoldering around, but has never blown up like the current coronavirus has, even though it's kind of caused all these pockets of outbreaks. And the reason is that people get just too darn sick. When they get infected, they get so sick that they can't move. They can't do anything. Everybody knows they're sick because they are just, unfortunately, they have a 30 to 40% mortality from the MERS coronavirus. And so they just get so sick, they can't spread. The old saying is, dead people don't cough. All right. If you can't, if you're not able to move and spread to other people, or if you're so easily recognized as sick, it's not very easy for a virus to actually spread.
It's fascinating. I've never heard it explained that way, but it is a fascinating concept. So this is one of the frustrating things is I know there's so much data out there, but the one number that I'm really looking for that I cannot find, and maybe you have it either locally or on a state, national, or perhaps world level, but I guess it probably is best answered anecdotally from what you've seen. So in March, as the disease was ramping up and it seemingly was killing far more people per infection rate, what are you seeing now? So in other words, if the mortality rate was 6 out of 100 patients in March, what are you seeing now per 100 patients? And I know you don't have hard data on that, but anecdotally, have you noticed that it is less deadly?
Well, we certainly have realized, and this is our experience as well as the experience across the United States, is that people, when they do get hospitalized, they don't seem to be spending as much time being hospitalized. They're able to go home a little quicker than they were in months past. They don't go to the intensive care unit as often, and when they go into the intensive care unit, they don't stay in the intensive care unit as long, and of course, they don't die as often. However, there are 3 things that we follow, and this is one of the reasons why people are always getting confused about the numbers, and they're bad, they're down, they're up, they're down. 3 things that we follow. The first one was, how many are we diagnosing? And that was all based on the test. We didn't diagnose nearly enough in the first wave. And that's one of the reasons why the numbers are so low. How many cases do we have on the first wave? Seems proportionately lower. We had more in the second wave. Why? Because we were able to test more. And we're probably going to see more in the third because we were able to test even more than in the second. That's the first one. The second one is hospitalizations, though. And that is a really key metric. When you're looking at the waves, the first, the second, and the third wave, look at the hospitalizations, because that is completely independent of whether or not you're able to test or not.
Sure.
And so when you looked at the number of hospitalizations, the first wave and the second wave were actually very similar to one another. Even though we were able to diagnose so much more in the second wave, the number of hospitalizations stayed constant. And we're expecting, we hope that our third wave won't get nearly as bad as the first 2 waves, but we don't know. But that's our one that's completely independent of our ability to test. And then the third number, and you're talking about the waves, we're looking at deaths. And the highest deaths was in the first wave, and then medium deaths in the second wave, and then less deaths in the third wave. But people are still being hospitalized, which is one of the reasons why, just because we see that the deaths are going down, doesn't mean that this isn't still very important, that we want to avoid it. Being hospitalized for 2 weeks is no fun. Just because you ain't dying doesn't mean that you want to be stuck in an isolated hospital room for several days or several weeks, with people helping you, being on oxygen, things like that. So it's still very important for us to see that people are still getting sick enough to be hospitalized, even if they're not dying.
I look at the numbers so much that sometimes it's almost like I'm lost in the forest. There are so many trees.
Yeah.
I think most of our viewers, and we could be guilty of doing this in the media, we tend to focus on new cases. And obviously we've seen an alarming acceleration to the point where yesterday's record number was 25% higher than our previous high, which was just a few days ago.
Right.
So we tend to get fixated on number of new cases that are diagnosed. In your view, what is the number? What is the most important number? What should we be looking at?
I would actually say it's probably hospitalizations gives you probably the best feel for what's really going on. Again, the number of cases that we diagnose is going to be based on our ability to diagnose. And so we're definitely better prepared now than we were a month or 2 months ago, and certainly better than in July when the second wave hit. So we have the ability, we have the reagents, we have the resources, we have the people, we can do a lot more testing. So we're going to find a lot more of those, remember those 1 out of 10 who didn't even know that they were infected, right? The asymptomatic cases. We're finding a lot more of them. So that's going to be a little bit misleading when we see all these new cases. That being said, we don't want to find any cases. We want all the cases to go down. But it's the hospitalizations that are really going to tell us where things are going in the community, whether or not you're able to test or not. And unfortunately, we're seeing hospitalizations trend up as well. And so that tells us that there is a rise. This is a third wave. It's, coming, if not actually already here. And it is something that we, as, members of our community in Northeast Ohio, we have to be very cautious so that we don't become one of those numbers.
Doc, as you know, a byproduct of this, an unintended consequence, is the anxiety that 330 million Americans are experiencing. It's unquestionable. If this virus hasn't touched you in a physical way, it most likely has affected you emotionally. And how we measure that's anybody's guess. Yeah. But I think what everybody's looking for at this point in the virus, we're coming into month 10. And for some, hearing that it's going to drag into 2021, and Dr. Fauci said it may be even into the next year before we see a true return to normal, whatever that will look like.
Whatever that will look like. Right.
Is what piece of good news, what piece of shining light of hope do you hang on to, and would you like to share with our viewers so they might realize that there is hope at the end of this, and we're probably closer to the end than we are to the beginning?
Right. Well, I would certainly tell you that there's a lot of good things. Listen, there's not much good about this pandemic. One of the good things about this pandemic, and it's something that has been very unique to this coronavirus, is that we have responded in a way that has not been seen since the HIV pandemic back in the 80s, where the entire country, the entire world has rallied. And you will see that the government is giving money, making resources available. The private sector is giving money, making resources available to help treat, to help detect, to help aid those people who are affected, whether it's because they're sick or whether it's because of all the problems that come from this pandemic, be it, the fatigue that we're getting from being in the pandemic for so long, all the economic hardships. There is a lot of people who have stepped up. So there's one thing I would say is that we as a world have really come together to fight off this pandemic. What we're waiting on right now, all our eggs in that basket of waiting for a vaccine, an effective vaccine, there have been over 150 vaccines that are in various stages of testing, 6 of which are in those, in that hyper speed program by the United States government, 3 of which are actually in phase 3 trials, the last phase before you're actually able to be, used in the community at large if, all the data is good. And so we are actually nearing the point where within the next few months, we will know whether or not we have a safe and effective vaccine. But just because we have one, we still need to make it. We still need to distribute it. We still need to prioritize who gets it, who doesn't get it. And that's why this is going to drag on into 2021. Even when we have a vaccine, we say that it's safe. We know that it's effective. We know that everybody can get it. We're still going to have to get to that point where we're able to make enough of it, produce enough of it, ship enough of it, give enough of it, and then follow people going forward. But I would definitely say that as the pandemic goes, this is going to be the worst year of it. But then as we've talked about, this virus itself is evolving, the disease severity is lessening, and that at some point in time, we will get to a point where we're out of what we call a pandemic phase, where we're talking about lockdowns, and we get to a point where we're more in, this is a virus that kind of rears its ugly head every so often, and then we're able to identify it. We have much better means of treating it and making sure that it doesn't spread everywhere. So this is going to be something that we're going to be dealing with for many, many years, but we're not going to be dealing with it like we are this year. Each year, things are going to get a little bit better, in my opinion.
Well, that's certainly the hope, and I know that's the hope of all of our viewers and really everyone in the world, is that this thing finally fizzles out and goes away. Quickly, before I let you go, on the vaccine front, I've been reading a lot about this risk manufacturing, Moderna and Pfizer, and some of these companies that are really deep into these phase 3 trials have gone ahead and planned for the idea that they are going to be successful and that they will get FDA approval.
Right.
How much closer does that get us to mass distribution of a vaccine should one of these punch through and get approval? Some of the estimates are in late November.
Right.
When might we be actually seeing individuals going to caregivers to be administered this vaccine?
Yeah. From a vaccine standpoint, what we're doing is we are betting on our success. Usually, a lot of companies will hedge their bets. They will basically make enough vaccine to get through the trials, and they will hold off to make sure that it is approved before they throw in all the money that's required for infrastructure and ramping up of production, et cetera.
Right.
In this case, right now, we're saying, no. We're going to invest the money now in anticipation that we're going to be successful, rather than waiting until we're successful. And this basically saves us months. Assuming that one of our vaccines, any one of them, and we only need one hit on the dartboard, right? So that's why we have 150 darts being thrown. The first 6 are going to be, fairly quick over the next couple of months. We get one good hit, then that's safe and effective. Then we're already basically ahead of the game in order to ramp up production. And that's one of the things that that's part of the government program, is that the government basically told the drug companies, we'll front you some money so that you guys aren't betting the whole farm, and then if you lose, then you guys are really, really in a bind. No, we will help you out because we need this vaccine as soon as possible. And so this is, again, part of everything coming together, that there really isn't too many stops from a science front, that people are trying to get things done as quick and as effective as possible.
I lied. I said last question. I had one other point that I wanted to go over with you, and that was when you look at the numbers, who the virus is killing. And I think the one thing that really stood out to me, and I compared the numbers to Ohio and nationally, they tend to mirror one another, really. In the state of Ohio, throughout this pandemic, there have been just over 400 deaths for people that are under 60 years old.
Right.
When you look at the number of deaths over 70, that obviously is alarming. And the juxtaposition between those two, it's almost 80% of the deaths are over 70 years old,
right,
where less than 10% of the deaths are under 60. Has identifying who this virus is most deadly for also helped in eliminating the transmission? Because what we've heard from the governor yesterday was the overwhelming number of new cases are people that are 55 and under. So if nothing else, we have effectively isolated the most vulnerable population. Is that also impacting, in your view, the mortality rate?
Well, certainly anybody can get really, really sick from this virus. And while you are absolutely correct that people 55 and older are much more likely to get sick, and people 65, 70 years and older are much more likely to succumb to this infection, the answer is that anybody can get bad. We've had children who have gotten really, really sick from this virus. There are a lot of people who are just, have immune systems that just aren't as vigorous, or they have underlying heart or lung problems, or they're getting cancer chemotherapy and things like that, that unfortunately stacks the odds against them if they also happen to get this virus, whether or not they're old or young. When we looked at the Centers for Disease Control came out with the first 1.5 million people who got sick. This was earlier this summer. The median age was 40. So that means 40 or 50% of all the diagnosed patients were over the age of 40, and 50% of all the diagnosed patients were under the age of 40. It just tells you that you can get infected in your 20s, in your 30s, in your 40s, even if you don't get sick, even if you aren't the person who's going to get hospitalized. We also want to make sure that you don't spread it to people who are.
Yeah.
All right, if you're in your 30s and 40s, you may have kids. And if you have kids, you may have grandparents or older uncles and older aunts. And we want to make sure that we are, preventing them. That's where the testing has helped us. All right, by testing and being able to expand our tests, we can find out who is sick so that they don't accidentally or inadvertently give it to someone who can get really, really sick from this virus. But there's absolutely no doubt that that the numbers of people who die are in the older age groups, people with heart problems, people with diabetes, and people with kidney problems. Those are the big ones that we have seen. But people with underlying lung problems, young or old, can all get sick. And it's something, when we talk about lung problems, asthma. How common is asthma? Very common. Yeah. Emphysema, COPD, all these, this virus makes that people who have those much, much worse. So it is something that we all want to avoid it. If not for us, for everyone else around us.
Doctor, that was awesome. I'm sorry that we stole so much of your time. I don't know if you blocked that much out for us, but I certainly appreciate it. And I think our viewers will too, because, a lot of times we're just throwing out the number of new cases and letting it lie there like a nuclear bomb and not really addressing what they mean.
Well, you get almost numb, right? You get numb to the numbers.
Sure.
And that, it's like, okay, there's more, but what does it mean and where are we going? And the answer is that, while we're watching these numbers because it's just such a big deal, the numbers right now are going up. And that means that somehow we have to, after we've been fighting this virus now for 6 months, we have to somehow be able to have the strength to fight it off again. And we're going to keep fighting it, keeping it down, waiting for the cavalry, which in this case is going to be the vaccines, to kind of come in, and we're just trying to hold the fort until that cavalry arrives. I will say this to one of the things that you also mentioned before. I don't think this virus is ever going to go away. All right. I don't think that this virus is going to fizzle out and basically, wave the white flag and say, okay, I'll calmly go into extinction. I think that we're going to battle it back to the point where it becomes like every other virus that kind of creeps up. People can get sick, and then, but, in this case, won't get as sick, or we're going to be able to recognize them before it really, really spreads badly. But I have a feeling that this is going to become like one of those flu things where we have flu season, we have croup season, we have all these other types of season. We're going to have a coronavirus season, which we're going to be watching out for. And if this coronavirus is like every one of the other 4 coronaviruses that have been around with us for decades, the coronavirus season is basically November to about end of February. And so this is going to be
kind of coincides with flu season, right?
What's that?
It kind of coincides with flu season, right?
Yeah, flu season for the most part, it really ramps up late December, early January. That's the big flu.
So this would be
but it can happen at any point in time between November and March. But the real big peaks that we see are usually around, at least in this area, usually around late December, early January.
Doc, I don't know if you know this, but how would you compare number of flu cases on this day in 2020 compared to the number of flu cases that we might. I know we're not in season yet, so you wouldn't expect to see this huge acceleration, but are we seeing fewer flu cases this year than normal? And if so, why?
We don't know yet, but we do know what happened during the summer down in Australia. Okay, when it's our summer, it's their winter. So our summer was their flu season, and they were also dealing with all the coronavirus and all the coronavirus precautions because they were wearing masks, because they were socially distancing, because they were doing all the hand washing. They did not see nearly as much flu as they had in years prior. We are hoping that will also be the case if we continue to work, do our jobs by wearing the masks and washing and socially distancing. We're going to prevent this virus as well as many, many other viruses. However, I don't expect flu to take the entire year off either. So there's going to be some influenza. And what we want to do, though, is to try to make sure that, we help people prevent flu. Flu is bad, too. And so that's why it's still very important for everyone to get the flu shot. Even though we're all talking about coronaviruses, the best thing you can do to help yourself against a really bad virus right now is to get your flu shot.
Well, fingers crossed, an unintended benefit of coronavirus would be a less deadly flu season. Hopefully that manifests itself.
We will know in a few months, yeah.
Fascinating, Doc. Listen, I hope you are well. It's great to catch up with you. Again, sorry that we took so much time, but really valuable information in all of this. I hope we can kind of boilerplate it down to the key talking points and give people a better idea of where we are.
Yeah, you just edit me to say yes or no. All right, and that's and everything else is throw it trash.
No,
it on
I
the
won't
floor,
do that.
right?
I promise.
Okay. Well, hey, Jay, it's very good talking to you again. Anytime you need me, give me a call. All right.
I really appreciate it, Doc. Take care. Have a great weekend.
You too. Bye bye.